Now, let's take microcytic anemias first. Well, microcytic anemia, a low MCV. Now, you know our basic pattern. Which of the following is the most likely diagnosis? What's the best initial diagnostic test? What's the best accurate diagnostic test? What's the best initial therapy? And at all points, what would you do next in the management of this patient? What's the most appropriate action? What would you do? What is the next best step? Action, do, management. So therefore, in microcytic anemias, we cannot distinguish these based on the symptoms. The symptoms of these are going to all be the same, not based on the etiology, but based on the severity. Therefore, we cannot answer the question, which of the following is the most likely diagnosis is iron deficiency, and which of the following is the most likely diagnosis, the anemia chronic disease, which of the following is the most likely diagnosis, the sideroblastic, just from the symptoms. Which of the following is the most likely diagnosis, thalassemia. We can't answer the question, which of the following is the most likely diagnosis, just off of the physical findings or the complaints, because the symptoms are the same, not based on the etiology, but on the severity of how bad the hematocrit has fallen. Iron deficiency anemia. How can we answer the diagnosis? Which of the following is the most likely diagnosis? Well, there should be a history of increased loss of blood, increased blood loss, because iron is not that necessary, because we only need 1 milligram a day when you're not menstruating or not pregnant. So men only need about 1 milligram. 1 milligram. Remember, 1/1000th of a gram, and you need 28 grams to the ounce. That means 28,000 of these. 28,000 for 1 ounce. 1 milligram, 1,000 of them to the gram, 28 grams to the ounce, 28,000. That means 1 ounce of actual iron would be enough to last you for your entire life, because the body recycles the iron. That's why we have haptoglobin. Red cells break down. That's why we have a spleen. Recycling that iron down to a general blood loss is you only need about 1 milligram a day. Now, that goes up to 2 or 3 milligrams if you're female, because you're losing blood with menstruation, and it goes up to about 5 or 6 when you are pregnant. So the person who has the highest iron requirement is the pregnant female at about 5 or 6 milligrams per day. Now, the only problem with iron metabolism is that your absorption is also about 1 or 2 milligrams a day, 2 or 3 milligrams a day in a pregnant woman, but the maximum absorption stops at about 4 milligrams to 5 milligrams a day. Now, that means if you are pregnant and you need 5, you're gonna become anemic. You have to become anemic. Why? Because you can't absorb that amount. So you gotta become anemic, because the body is not meant to absorb that amount of iron. And therefore, all pregnant women should be on iron replacement, and all pregnant women can become anemic. That's part of the deal of increasing the plasma volume by 50%. It's a 50% increase in plasma volume, and it drives the hematocrit down. Now, iron metabolism is very tightly regulated. You only need 1 or 2 milligrams a day if you're menstruating, 2 or 3, pregnant 3 or 4, maybe 5. But the maximum absorption stops at about 4 milligrams. On the other hand, maximum excretion, well, you're only excreting 1 or 2 milligrams a day too. And if you need to excrete more, you can't. There is no natural method for the body to naturally say, let's excrete more iron today. You'd have to bleed yourself. You would have to do phlebotomy. You would have to start menstruating. You would have to scrape skin cells off your skin. you would have to have some form of cellular loss. There is no natural way to increase iron excretion from the body. That's why people who get over-transfused from thalassemia, that's why people who have thalassemia major, that's why people who have thalassemia major all get hemochromatosis. That's why they all get hemochromatosis, with iron built up in the liver, iron built up in the heart, iron built up in the pancreas, iron built up in the skin, iron built up in teeny witsy wootty bitty tiny raisin testicles made of steel. They have to get the iron built up because here you only need 1 or 2 milligrams a day, but you can't excrete more than 2 or 3 milligrams. Well, 1 unit of packed cells, these people are getting transfused with thalassemia major. They're getting transfused with thalassemia major, getting transfused 2 to 4 units a month. Minimum 1 or 2, maybe 2 units a month. Now, a unit of packed cells, a unit of packed red cells contains 1 milligram per milliliter of iron. If there's about 350 mLs per unit, that means that the person is getting a year's worth of iron minimum every 2 weeks. If they're getting 2 or 4 units a month, even at the smaller value of 2 units a month, that means every 2 weeks you're getting a year's worth of iron. That means at the end of a year, you have received years worth of iron. That means you have received half a lifetime's worth of iron in a year. So you have to be iron overloaded because you can't excrete the iron. You don't need more than 1 or 2 milligrams a day, 3 or 4 if, later on, 5 if you're pregnant, but you can't absorb that much anyway. You need 1 or 2, your maximum absorption is about 4. You can't excrete more than that either. It's tightly regulated. You need 1 or 2, maximum you can absorb is 3 or 4. If you need more than that, you can't do it. You excrete 1 or 2, maximum you excrete is 3 or 4. If you need to excrete 5 or 6, you can't excrete it. Where does it go? Hemochromatosis, liver disease, joint pains, infertility, heart disorders, pancreas. That's why the treatment for thalassemia major iron overload is deferoxamine, because you can't do phlebotomy on these patients. You can't do phlebotomy on these patients because they're being transfused every 2 weeks, so you can't do phlebotomy if you need the blood. Can't bring them in on Monday and transfuse, come back Tuesday and we'll drain it out of you. Come back Wednesday and we'll transfuse, come back Thursday and we'll drain it out of you. You got to deferoxamine. Deferoxy-you? No, deferoxamine. Get this iron, ferrous. Get that ferrous off of me. The same thing here with iron metabolism. The excretory rate is tied to the same concept of why people with thalassemia major get hemochromatosis and have to be treated with deferoxamine. Iron deficiency. You can't distinguish it based on the symptoms from the other. Iron deficiency. Look for some form of increased blood loss. If you lose even a few milligrams of iron a day that are extra, you can't absorb it and compensate for this. If you're losing as little as even a tablespoon of blood a day in your stool from colon cancer, you're going to get iron deficiency anemia. A 60-year-old man comes to the office because he's feeling tired. And this tired guy has got himself a hematocrit of 30 and an MCV of 60, or 68. Let's make him 68. Normal being 80 to 100. A normal MCV being 80 to 100. His stool guaiac is negative 3 times. What is the next best step in the management of this patient. You got a 60-year-old guy, tired guy, coming with a microcytic anemia. He's got no blood in his stool 3 times. No blood, no blood, no blood in that stool. What are you going to do? Colonoscopy. What are you going to do next? You're going to do colonoscopy anyway. You're going to do colonoscopy anyway because even if the stool is negative, there is such a high association of microcytic anemia with colonic cancer that you're going to do the colonoscopy anyway to exclude the GI malignancy. Well, why'd we do the stool guaiac? I don't know what you did. I didn't tell you to do it. I just told you it was done. I didn't say you should do it. I'm just saying it was done. What's the point? Is that negative stool guaiacs in an older person with microcytic anemia does not eliminate the need for endoscopy because they're not sufficiently sensitive to exclude the colon cancer. That's why people above 50 should get scoped to be certain. Microcytic anemias with negative iron studies in the stool, scope them anyway. Thank you very much. Now, what should you look for to suggest? And by the way, GI loss is the biggie. That's the biggie. Remember, you are looking at a 6 to 8% risk of colon cancer in your lifetime. Yes, even you, right there, 6 to 8% if you're on a bacon cheeseburger, fat-filled, low-fiber, Wendy's, McDonald's, supersize my rectum with disgusting low-fiber, high-fat bacon cheeseburgers. We are looking at 6 to 8% risk of colon cancer. In the future, colonoscopy will just be considered a part of normal good hygiene, like flossing your teeth every once in a while. It'll just be the right thing to do. Now, chronic disease, different from blood loss, is any chronic disease. I have rheumatoid arthritis. It makes me anemic. I have many forms of cancer. It just makes me anemic. I have somebody who has end-stage renal disease. That's more identifiable. That is the person who has no erythropoietin. But you know what? Most chronic diseases, from things like metastatic cancer, rheumatoid arthritis, and other connective tissue disorders, there's not a blood loss and it's not erythropoietin deficiency. There is something about chronic diseases that some of them elicit a factor that make it impossible for the iron to be taken out of stores and have it be produced into red cells. There's something about it that makes it impossible to take the iron out of stores and make red cells with the iron and make it into hemoglobin. What? We're not certain. Why do people with cancer get hypercalcemia? A parathyroid hormone-like particle is made and it makes the calcium go up. Why? I don't know. Why do people with cancer get hypercoagulable and clot? Why do they form deep venous thromboses? Why are they hypercoagulable? I don't know. Figure it out. Then you go to Stockholm and you go get a Nobel Prize, because that would be worthy of a Nobel Prize, to figure out why you get anemia, why you get hypercalcemia, why do you get people who are hypercoagulable, which more properly is called thrombophilia. I love to thrombose. Are you hypercoagulable? Well, I'm a little hyper, yeah. But are you hypercoagulable? I'm hyper, but I don't love to thrombose. Thrombophilia. Why? Don't know. That's just the way it is. Now, any form of chronic disease, you cannot distinguish it. Sideroblastic. You're looking for a particular toxin in the history. What is the most common toxin to cause sideroblastic anemia? You are probably thinking lead. But it's not lead. Lead can cause sideroblastic. However, you can't go across the street to the grocery store and get a 6-pack of lead. You can't go to a restaurant and say, I'd like a lead and tonic. You can't get a Cosmopolitan made with lead. I want a Chateau Neuf de Pape 1973 with lead. Alcohol is the most common cause of sideroblastic anemia. There are far more people drinking than taking isoniazid. Most of you have never had isoniazid, but more than a few of you have had a drink. Oh, but I'm not an alcoholic. How do you know that? Well, I can still pay my bills. But the thing is that even if you drink even a little bit, it's still more common than people who've been on isoniazid. There's only 16,000 cases of tuberculosis a year in the entire United States. What should suggest sideroblast? Suggest? Well, couldn't you be an alcoholic with iron deficiency? Yes, you could. But they're suggestive. Which of the following is most likely to be associated? The questions don't say, yo, dude, which of these is it for sure? It doesn't say that. It says, which of the following is it most likely to be? Which of the following is it suggested to be? Alcohol, lead, isoniazid, but alcohol is number one. Thalassemia that's major, that's a pediatric disease. It becomes obvious by the time you're 6 months old, because by the time you're 6 months old, you're either getting transfused or you are dead. So we are mostly concerned with adult diseases here. I am not the pediatrician. I am childish, but I'm not a pediatrician. We are concerned mostly with thalassemia minor, also known as thalassemia trait. And most of the time, you don't feel a thalassemia trait. You have very, very, very small red cells, a profoundly low MCV, but you don't have many symptoms because the body increases the red cell count in order to compensate for that. So the total hemoglobin and hematocrit might stay closer to normal because the body is increasing the red cell count to make up for the fact that the cells are much smaller. Which of the following is the most likely diagnosis? Very hard to tell from history and physical. Iron loss, blood loss should suggest iron deficiency anemia, but it's not quite good enough. You can't tell by physical exam. There is nothing on physical exam that's going to tell you for sure which of the following is the most likely diagnosis. And on a regular CBC, you're not going to be able to see anything either. Microcytic, 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 microcytic. Low retic, low retic, low retic, low retic. Smear tells you half the time in only one of these. The only one in whom there is an abnormal smear is thalassemia. Sometimes the smear will show you target cells. Now, target cells are found in other things except thalassemia. You can see them in liver disease. So that means that target cells are not specific just to thalassemia. It also means you could have thalassemia without targets, and you could have targets without thalassemia. However, if the question is, which of the microcytic anemias is most likely to be associated with target cells, the answer is thalassemia. The blood of the people from the sea. Thalassa is a $5 word in Greek for the sea, having been described originally in Mediterraneans and Sicilians, the people who are near the sea, the Mediterraneans. Now, by name, that wouldn't tell you what it was now if you didn't know what that meant, and then you know that beta thalassemia was originally described in the Greeks and the people around the Mediterranean. It's not like the anemia of chronic disease. I can call up my mother. Hello, Mom. Yes, dear. I think I got the anemia of chronic disease. What do you think it's from? Do you have a chronic disease, honey? Hello, Mom. Yes, dear. I need to treat my anemia of chronic disease. What should I do? Well, get rid of the disease, honey. So even my mother can tell me that. Now, my mother's the chief of hematology at Harvard, but she can tell me because it's implied in the name. You can't figure it out not just from the thalassemia. From the name, anemia of chronic disease, iron deficiency, you can tell just from the name. The smear does not help you very much. The regular CBC does not help you very much. Iron deficiency anemia is most likely to have an elevated RDW, red cell distribution of with red cell distribution of width. It's the one most likely to have an elevated red cell distribution of width. Now, what the hell does that mean? It means it's the person who has cells that are not all the same size. Now, the RDW does not tell you if it's big cells or small cells. The RDW just tells you whether they're the same. If all of your cells were the same size, the RDW would be small. In other words, the cells have the same size. There's no distribution of width. Now, it doesn't tell you whether they're all big or they're all small. It just says, are they the same? It's like standard deviations. It doesn't tell you what the grade was. It just says, are the grades all the same? So in iron deficiency anemia, it's the one most likely to have an increase in the RDW, the distribution. They're not the same. Now, as time goes on in your iron deficiency anemia, you like that gesture? Time goes on in your iron deficiency anemia, are the new cells bigger or are the new cells smaller? Whisper. The new cells are smaller. What? I thought they were bigger. Well, ordinary red cells are bigger. The newest cells, the ones that were just born from the marrow at a day or two ago, the reticulocytes, because the reticulocytes that have just come out of the marrow a day or two old are slightly bigger because the individual cell is born a little chubby, like baby fat. And then it slims down over a couple of days. However, as time goes on, I'm becoming more anemic because I'm running out of hemoglobin. I don't have enough hemoglobin to fill my cell. So I'm becoming more anemic. The cells are smaller because 3 months ago I had more hemoglobin than I do now. And remember, the red cell is a hemoglobin-filled bag. The cell membrane is like slices of bread or a roll. And the hemoglobin is the meat and the food in the sandwich. If you run out of food, you tend to make smaller sandwiches. And the newer cells are more deficient. An individual cell is born out of the bone marrow, chubby and fat, and then slims down as it becomes grown up. But the new cells are more deficient. So the distribution of the width goes up. This is the only one. Chronic, all the cells are the same size because you have time for them all to be the same. And in these are more long-term. This is a lifelong disease, so all the cells are small lifelong. They're all small. So the distribution of width is lower, since they're all the same in those disorders. Smear does not help you. Hypochromic, microcytic, they're all microcytic. Reticulocyte count can be down in most all of them. So how am I going to distinguish between these? Is iron studies. The way that I'm going to distinguish between these is the iron studies first after the CBC. In hematology, it's easy because you say, well, no matter what test I'm getting, it's always CBC first. Probably it'd even be given to you. But what test will confirm it? Iron studies. Iron deficiency is the only one that has a diminished ferritin. The only one that has a diminished ferritin. The decrease in the storage form of iron. It's the only one that has a decreased storage form. Decreased storage iron equals iron deficiency anemia. Because both iron deficiency and the anemia of chronic disease have low circulating iron levels. They both have low circulating iron levels. So therefore, that will not tell the difference between these. They both have low circulating iron levels. Now, the problem with a ferritin is that a ferritin is an acute phase reactant. The ferritin, like many plasma proteins, goes up in response to physiologic stress. I've got cancer, I've got sepsis, I have generalized infection. I'm feeling terrible because I have this physiologic stress. I've had trauma, I've had sepsis. I have some other physiologic stress. My white count has gone up, my sedimentation rate has gone up. C-reactive protein, ferritin, transcobalamine, the carrier protein for B12. So therefore, these proteins go up. Ferritin is like a white count. It goes up from the stress. B12 carrier protein goes up like the rest. The ferritin goes up in response to stress. Therefore, since it might sometimes be normal, we need another test. Increased total iron binding capacity. You might think I do those every class, but that one was spontaneous. So the thing is, total iron binding capacity. Just for you out there in videotape land, I love you. How can he love us? He doesn't even know who we are. Philos in the Greek, my buddy, my friend, my pal, affectionate. I love you, you love me. Eros, Plato said, the yearning of the soul for the realm of the divine, or romantic love. I love you, you love me. Philos, eros, but agape. I don't even have to know you, and I can care about you. I love you. Increased total iron binding capacity. The capacity goes up because the red cells are becoming empty of iron. So the capacity goes up because they're empty. They're empty. They're empty of iron, so therefore you have more empty seats. If all the seats are filled, the capacity is down. If all the seats are empty, there's not much iron around. Here in anemia of chronic disease, we have a low TIBC. We've got lots of iron packed up in our cells, and if we stain it, you will see lots of ferritin throughout the body. Low capacity because it's all filled. Don't just pour in a lot of iron or the patient will be killed. Therefore, this is all you need to diagnose the anemia of chronic disease. The reason that we need that iron binding capacity is ferritin is an acute phase reactant. White count, sed rate, C-reactive proteins step on my toe when they go up. The ferritin level might artificially be normal. Get a TIVC in your workup. How do we tell when the carrier protein is artificially normal? Now, of all the tests, what is the single most accurate test for iron deficiency anemia? More than all the... Oh, what would we do? No, did I say what would we do? I didn't say what would we do. I said what's the most accurate. Do you know that one of the major things that you come in to learn in the Step 2 class is not the tests and the treatments? Do you know that most of the time you've actually heard of them before you get here? Only 10 to 15% of the data you're going to get is 100% brand new. Most of it is somewhere in your mind in an archived file because these are review courses. You've heard it somewhere, but you don't know quite what to do with it. Most of what you're learning is not that you have never heard of a beta blocker. It's not like you never heard of deferoxamine in most cases. But when to use it, the beta blocker versus the calcium blocker. So it's not that you haven't heard of things, it's when to use it. So when I say the question, what's the most accurate test for iron deficiency? I didn't say what's the most accurate test that you routinely do, or what are you going to do, but what is the single most sensitive test? And it is a bone marrow. Oh, go on, Conrad. You're not going to do a bone marrow, laying them on their stomach and poking holes in their hip and their iliac crest? Oh, come on. Even an aggressive guy like you is not going to do that. And it's true that I would not routinely do that. But it is the most, what's the most accurate test for a pulmonary embolus? It's an angiogram. It's an angiogram. Oh, so you're going to do an angiogram? I never said I'd do it. It's the most accurate. Hey, what's the most accurate test for otitis media? Oh, I know that. After all, what could be more common? What could be more easy? Otitis media. What's the most accurate test? Oh, looking for red bulging membrane. No. Looking for immobility of the tympanic membrane. I will now be a tympanic membrane. Immobile. No, that's the most accurate thing on a physical. But the most accurate thing for otitis media is tympanocentesis. Take a needle and see what organism is actually in there. That's the most accurate. You're going to do tympanocentesis? I never said I'd do it because I wouldn't put the little kid through it. But if you want to know the diagnosis for sure, that is the only way to know for sure what the organism is. What would I do? I'd see an immobile tympanic membrane, give the kid some amoxicillin. Pulmonary embolus. What would I do? Oxygen and heparin and oxygen, do the VQ scan or the spiral CT, particularly if the x-ray is abnormal. What would I do? I'd get an iron, a TIBC, and ferritin. I'm not going to give them marrow. Why are you telling us that? Well, what's the question? You know what the questions are going to be? Maybe this year they ask, what's the best initial test? Maybe next year they ask, what's the most accurate test? Maybe the year after that, they ask you what the hell an RDW is. You don't know what the question is. Could be each one of these. You think that they don't know that you talk to each other about these questions? I would rotate the questions around. Hey, dude. They got an iron deficiency question. Say bone marrow, bone marrow. You walk in there and go, yeah, I'm going to say bone marrow. I'm going to say bone marrow. I'm going to say bone marrow. And the question says, what would you do first to establish the diagnosis? And you go, bone marrow. They told me when I see iron deficiency, say bone marrow. No. The question might have said most accurate before. Maybe it says best initial now. What is the question? What is the question? That's all you need for the anemia of chronic disease. Sideroblastic anemia, what's unique about it is it's the only one that has a high circulating iron. The only one that has a high circulating iron level. Oh, only, solamente, tolka, nimnoga, iron level. Okay? The only one of these that has an elevated iron level. The others either have a low one or a normal one in thalassemia. Now, the reason that we're spending all the time on diagnostics is because in hematology, I have always thought that you're not going to get asked the treatment. Walk down the street. Hey, yo, hey, what? Hi, how are you? What do you want? What do you want? I have a random question for you. What's that? Hey, listen, if you're deficient in iron, what would you treat them with? Get away from me. Give us some iron. Hey, what? Who are you? What? There's B12 deficient patient. What would you treat a B12 deficient person with? Get away from me. Give him B12. If you walk down the street and talk to the hot dog man and say you're deficient in whatever, he's going to tell you, well, honey, give it to him. So I doubt that they will ask you the treatment for iron deficiency. Hey, the treatment for iron deficiency. Doc, hey, it hurts when I do that. Don't do that. Doc, it hurts when I'm iron deficient. Have some iron. Doc, it hurts when I have a chronic disease. Treat the chronic disease. The only one in whom you should give erythropoietin is the person with the end-stage renal disease. Don't give the erythropoietin to the routine person. Only the person with the end-stage renal disease will it work. What is the least efficient way, the worst absorbed way to replace iron? Ferrous sulfate, the stuff that we use every day. The worst way to replace iron is with ferrous sulfate, the stuff that we use every day. 98% of it goes out in the stool. That's why it turns the stool black, because it's not absorbed. If it was absorbed, It wouldn't turn the stool black. The most effective way to replace iron is with a blood transfusion. Are you telling us to use blood transfusions to replace iron? Did I say that? I didn't say that. I just said it's the fastest way to replace iron. What's the words that are used? Oral ferrous sulfate is the least effective. What would you do? Take some oral. Okay? I wouldn't do it. Okay? Okay? Because it's going to be malabsorbed. What would I do first? First thing that we're going to do is oral. Now, intramuscular is faster, but if you need iron so quickly, why would I use intramuscular iron? If you need iron quickly, you should probably get a blood transfusion. If you don't need it so quickly, you should probably get oral. Well, who's getting treated with intramuscular iron? The person who A, needs to be transfused all the time because of chronic blood loss, or B, that person who's always refusing blood that needs a transfusion? That person, that's the ethics question. What are you doing with that Jehovah's Witness who's refusing a transfusion, besides letting them die of anemia? Well, I don't know. They have the right to die, so we let them die. Very compassionate. Very compassionate. Excellent. Gee, you are qualified to be a pastry chef at the plaza. No, that's a Jehovah's Witness person who's got iron deficiency anemia from blood loss, who won't allow the transfusion. That's the person who gets intravenous or intramuscular iron. I want to transfuse, I really do. I'd like to transfuse you, but I can't because you won't let me, or I can't do it. Intravenous or intramuscular iron. The treatment of chronic disease, fix the chronic disease. What is the single most accurate test for sideroblastic anemia? The single most accurate is not a regular blood smear. No, because the regular blood smear just shows microcytic cells. We want to see the smear in which the iron, which is sidero, it's a $5 word for iron, abnormal iron buildup, sidero, abnormal iron buildup, sideroblastic anemia, the iron built up abnormally in the mitochondria. Help, help, I'm stuck in the mitochondria. I can't get out of the mitochondria. I got lost on my way to making hemoglobin, and I got trapped in the mitochondria. The stain to look for the ring sideroblasts, which is iron built up in the mitochondria, is a Prussian blue stain. A Prussian blue stain. A Prussian blue stain looks for iron built up in the ringed sideroblasts. With a Prussian blue stain, iron built up in the ringed sideroblasts. And that's the single most accurate test. The therapy for sideroblastic most often is knock off the toxin. Knock off the toxin and you won't have this anymore. A small number can be treated with pyridoxine because there is a, you're going to love this name, ready? This is where I start acting like a grown-up and start sounding socially appropriate. The majority of patients with sideroblastic anemia are secondary to the use of over-ingestion of alcohol. This prevents the absorption and the incorporation of iron out of the normal hemoglobin into the red cell. Therefore, the iron builds up in the mitochondria. On rare occasion, there is a hereditary deficiency of delta-9 aminolevulonic acid synthetase. These patients who are deficient in delta-9 aminolevulonic acid synthetase will end up being deficient in pyridoxine. If you are deficient in aminolevulonic acid synthetase, you treat it with pyridoxine. Aminolevulonic acid synthetase. By the way, that's a 90th percentile answer. You could easily pass step 2 without needing to know that. So if you're the kind of person that goes like I did when I was in medical school and goes like this, do I really have to learn aminolevulonic acid synthetase? Can I pass without needing to know this? Yes, you can. Now, if that's your style, you can get a nice 80 or an 82, and you can hug the 50th percentile if you want to, and you don't need to know sort of stuff like that. But there are others of you that are obsessing about your 95. So if you're trying to get a 95 and a 97, there are certain of these things that will help you. If you're mostly majoring in beer and introitus, then you don't need to know this. So, on to thalassemia. Thalassemia is the only one that is having normal iron studies. All the forms of thalassemia have normal iron studies. So thalassemia is very simply microcytic anemia with a normal iron study. So microcytic anemia with normal iron studies. Now that does not tell you which form of thalassemia that you have. You might have alpha thalassemia and you might have beta thalassemia. It doesn't tell you which one you have. What you do to tell you that is the electrophoresis. The electrophoresis will help you to know, do we have alpha thalassemia? Do we have beta thalassemia? And remember that thalassemia means that you are deficient, missing the type of chain that it's named after. So if you have alpha thalassemia, it means you're missing the alpha chains. And beta thalassemia, you're missing beta chains. It's the one that you're missing. Now, if you want a 50th percentile answer, the 50th percentile, where's my next beer and when is this tape over because I want to move type of answer, then your answer is this. Microcytic anemia, get the iron studies. The smear will show you target cells with thalassemia. Look for the low ferritin, look for the low TIBC, look for the high iron, get a Prussian blue stain. Look for the normal microcytic anemia with normal iron studies with thalassemia. There's no treatment for trait. Next, you may now leave. Now after you leave, we're going to talk about macrocytic anemias, but you may still leave for a little while. Now, if we're looking to get all the way here, the alpha thalassemia, I'm missing alpha chains. The beta thalassemia, I'm missing beta chains. So normal hemoglobin A. No, not this. I hated this. 2 alpha chains plus 2 beta chains. I know why you hated this, because you learned it from hematologists. And the fastest way to not understand this is to learn it from hematologists. Because there are no new hematologic diseases and there's no new hematologic tests. So if there's no new hematologic diseases and no new hematologic tests, because everything I said on the board behind me was true in 1973, how do you make yourself useful if you're a hematologist? You make it as confusing as possible. You cannot understand the hematology. You must consult me. You need me because you can't figure out an electrophoresis. Don't try. It will make you have a seizure. The new part of hematology has to do with a little bit on hemolysis and the whole other 3/4 of the section, which has to do with hematologic malignancies. Those have changed. Treatment for myeloma, treatment for CLL, treatment for hairy cell leukemia. That's what has changed, is the hematologic malignancies. The treatment of CML changed dramatically in the last 2 and 3 years. That's where almost all the changes are. This part, this very part here, this is the only part that's constant. So we have to make it as confusing. Hemoglobin A2 is 2 alpha chains plus 2. Hemoglobin F, fetal hemoglobin, is 2 alpha chains plus 2. Now, no doubt some of you out there, knowing more Greek than me, will say, yeah, give that little delta sign, which I can't understand. So I'm going to say 2 alpha chains and 2 delta chains, because I don't know how to do a Greek delta. And some of you will say 2 alpha chains and 2 gamma chains, but I'm not smart enough to know how to do gamma in Greek. I don't know that, so I'm going to say gamma chains. Beta, delta, gamma. Now, if you are having beta thalassemia, you don't have enough beta chains. So if you don't have enough beta chains, you've got to deliver hemoglobin to the body. And the body is out there saying, hey, where's my hemoglobin order? Where's my hematocrit? It's like an angry guy at a busy restaurant. Hey, Where's my order of hemoglobin? I got a body to perfuse here, you know. The brain is not going to understand when you have not delivered the hemoglobin hematocrit to me. Don't tell me about your problems about the fact that you don't have enough beta chains. Have you ever seen the heart and getting this thing to pump 60 to 80 times a minute for an entire lifetime of 79 years? It's not my problem. Get me my hemoglobin. I've got organs to perfuse. And the bone marrow goes, oh my God, what am I supposed to do? Look at this, I can't believe it. It's not my fault I got a genetic disease. What a lousy body. I got this genetic disease in this body. What a lousy body. How about we change the body and get rid of this one? Oh no, that's not so good because I die with it. That's a bad idea. So I've got to get more hemoglobin out of that bone marrow. How do I get more hemoglobin out of the bone marrow when I don't have enough beta chains? I got tons of these alpha chains lying around, but I don't have enough of these beta chains. I got plenty of alpha chains, but I don't have enough beta chains. And meanwhile, the macula densa and the erythropoietin-producing organs are pissed as hell at me that I don't have enough hemoglobin and hematocrit out in the circulation. Well, if I got all these alpha chains but not enough beta chains, my level of hemoglobin A is diminished. So what the bone marrow does in order to complete its order of hemoglobin and hematocrit is it takes the alpha chains and switches their binding to delta and gamma chains. I got all these alpha chains, and it starts delivering increased A2 and increased fetal. And says to the juxtaglomerular complex and the macula densa and the erythropoietin organs and go like this. Listen, I know hemoglobin A2 and fetal hemoglobin is not ideal, but I'm giving you what I can. I got to deliver hemoglobin, so what I'm doing is in order to maintain my order of hemoglobin, I'm increasing the A2 and increasing the fetal to try and make my hemoglobin, to keep the other organs happy. And that's the diagnosis. Now, alpha chains and beta chains, alpha chains are in all three of these forms of hemoglobin. Therefore, they'll all be down, so you can't use it to distinguish between these because alpha thalassemia, all three cell lines are down. All three hemoglobin lines, I should say, are down. So remember, the electrophoresis does not tell you the total quantity. It just tells you the proportion. They're all down, but they're down proportionately. So the hemoglobin electrophoresis will show normal 96% A, 2% A2, 2% fetal. They're all down. Alpha thalassemia, when you have alpha thalassemia, all three types of hemoglobin will be down. And how you tell these apart is that you have an electrophoresis. One either has increased fetal in A2 or it doesn't. And that's how you tell them apart. And as for alpha thalassemia, we know that there are 4 genes controlling that alpha chain. Now, if you're deficient in 1 gene, 2 genes, 3 genes, or 4 genes, the hardest part of this whole section is the annoying fact of the number of genes deleted and describing each one. But let us make it simpler. 1 gene deleted, you never hear from them. They never call you. You don't need to know anything because 1 gene deleted, they never page you, they never call you, they never bother you. 1 gene deleted, they don't show up at clinic, they don't wake you up in the middle of the night, they never show up for their clinic appointments because the 1 gene deleted is the 1 gene deleted expresses itself simply as the it's the person who's the silent carrier. Silent is a poetic term for a person who can't spell. The silent carrier is the person who has no symptoms. They never call. They never wake you up. They never show up for their appointments. They are asymptomatic, otherwise known as normal. 4 gene deleted, they never show up either. They never page you, they don't call you, they don't wake you up in the middle of the night, they don't show up for their clinic appointments either because they are dead. They never get born. They die in utero in the 4th or 5th month. So they're dead. They don't show up. They can't get out of the uterus. They're dead. And then 2 gene deleted is mild alpha thalassemia. 3 gene deleted is moderate thalassemia. And that's how you distinguish between these. Now, microcytic anemias, you can't tell them apart based on the symptoms. It's not the etiology, it's based on the severity. It's not the etiology, it's based on the severity. If you have a hematocrit of 25, you're going to feel the same with all these. Is there a reason for increased blood loss? I think it's iron deficiency. Chronic disease, chronic alcohol ingestion. I have a person here, I get iron studies in all of them. I have a low ferritin, I have the low TIBC, I have the high circulating iron, microcytic anemia, normal iron studies. Microcytic anemia with normal iron studies get me an electrophoresis. I either see an increased A2 and increased fetal, or I don't. What's the treatment for thalassemia trait? There isn't any, because you can't treat a trait. Just remember, Mama always said, honey, if you have a recessive gene, just make sure you always get a hemoglobin electrophoresis on everyone you date. Oh, yeah, listen, hey, I think you're cute. Oh, I think you're cute too. Listen, we should go, oh, yeah, I'd like that. Okay, I just need something a little from you. My phone number? Oh, no, red top tube of blood? If you're going to reproduce with people with genetic defects, just make sure that they are people who have different genetic defects than you do. Dr. Fisher's dating service. Please submit 2 red top tubes of blood. Well, one's for the electrophoresis. What's the other one for? HIV test. So you always reproduce with people who have different genetic diseases than you do. Mama always said to me, honey, don't build up recessives. We don't want to have to karyotype your children. Increased A2 and increased fetal or not, there's no treatment for a trait. You can't treat a trait. Just don't make babies with people who have the same genetic defects that you do.